Good afternoon, everyone. My name is Alex Wellstead. I'm here on behalf of Novartis. Thank you for being here. Thank you for coming back after lunch. That's the big part of this, all right. But, you know, Melody was mentioning this, but I think what I just want to reiterate to everybody, this panel is about something very practical. How we actually connect patients in rural, remote, and Indigenous communities to radiotheranostic care. And not in theory, but in actual real life. So when we're talking about connecting to care, we know that there are barriers throughout all of this. But we know that it's not just a clinical thing. This is referrals, imaging, geography, workforce, trust in the system, a whole myriad of different things that we'll get into. But my role here today is to keep this conversation pretty grounded. I'll try to move us from describing the problem. I'll let them describe the problem. And then we can talk about what we can actually realistically do as well. And hopefully we land on a few things that are, tangible and real and actually feel solvable. So let's actually start there. And feel free to introduce yourself as we go here. But Carlos, I'll start with you. When we talk about what those barriers are, so let's actually make this real. What are the biggest barriers today for patients in rural, remote, Indigenous communities trying to access this kind of care?
Thanks everyone for having me on the panel. For me, coming from Isologic, I'm Director of Operations there. Our biggest challenge is decay management, and as such, like having proper infrastructure, transport even to get over there is very important. Something that I came to learn about in my role is that patient transfer infrastructure does exist, but could be a little lopsided sometimes. A lot of these patients are forced to pay out of pocket for all the transport, and it could be, thousands of kilometers that they even need to travel sometimes. And then they get reimbursed later. However, it doesn't always work so well if we're putting the cost on the patient. So other structural issues include infrastructure. Like there just isn't enough, in my opinion. But it could raise potential for discussions for other modalities that exist or routes such as mobile PET units, something we've been discussing at Isologic, having and serving the remote places. So if they don't have access to, say, clinical departments or something like that, but maybe that's a viable option. It's an expensive one, we know, but something that could maybe be explored. And overall, like awareness and human resourcing, they need the expertise up there. They need the awareness of what nuclear medicine is, the benefits of it, just the public knowledge overall. And
Ian, how about for yourself? I mean, you can see it from the perspective of a community that's pretty close, but kind of feels far away.
Yeah, I'm mayor of the city of Owen Sound, which is the largest city in what we call the clean energy frontier. So that's Grey County, Bruce County, Huron County, and includes the two communities of the Saugeen-Ojibwe Nation. We have a regional hospital in Owen Sound that has oncology, does not have radiation, therefore doesn't have isotopes as of yet. 2.5 to 3 hours from Toronto. My wife, about 15 years ago, had cancer. Surgery in London, surgery in Owen Sound, chemo in Owen Sound, radiation here. Here because we had a friend that lives a couple of blocks away and she could come down to Princess Margaret every day for a treatment for 5 weeks. People in Owen Sound have to travel to get even radiation. It could be Barrie, it could be Kitchener, it could be London, it could be Toronto. Not everybody can afford to take time off work, to leave the kids at home, to deal with that travel. So what are our challenges? Distance, certainly. Time, the time to be able to get there. Long-term, probably people, having trained people in our local communities to be able to administer the programs. And of course, money pays for everything. So that's what we want to see in the hinterland, beyond the walls of the great city. For isotopes, the best doctors have to be where the money is, and they are doing their trials and things in London, in Toronto, in the major cities because they have to be. They will have a team around them. The trick will be to get them to put a team member that's out in a different hospital to work with them, to break down, I think we talked about earlier, it was mentioned silos, being able to do the treatments in the hinterland in regional hospitals, but still being centered and focused here in Toronto under the best specialists.
I kind of regret asking for the biggest barriers because they are huge, but I really appreciate you making that real as well. So what it sounds like is it's everything, right? Like this is referrals, this is geography, this is every step of the way is not an easy one in these communities. Carlos, if we can go down a bit more on the logistics and what actually breaks through that, I'm curious, the treatments are fairly tight on timing and coordination. From your perspective, what's the hardest about getting them to patients outside of major centers?
It's a good question, and this is something that Isologic actually really excels at. We're a great radiopharmaceutical company, but we're an exceptional logistics company, actually. If you have a license and you have a department, we are getting to your site no matter what. We have almost 99.9% logistics success rate. So, on a daily basis, we're driving to Sudbury from our Toronto facility twice a day. We're going as far as Val-d'Or. There's a lot of reasons how we make it happen. You have to have multimodal logistics. You can't just rely on ground. You have to have partnerships with charters. You have to have partnerships with, say, cargo distributors like Air Canada Cargo or Purolator, and you have to explain to them the importance of what we're shipping. We're not just shipping, an empty box. This is life-treating medicine. It's, in a lot of cases, like there are instances where in the past, it's not so much anymore, that our boxes were, or our shipments were being put aside or left for the next plane because, there's a bunch of baby chicks on the plane and they can't be irradiated by the dose, and it kind of just doesn't make sense. So explaining to the cargo companies or whoever's ahead of logistics and kind of familiarizing them, gaining the awareness of how important this is to Canadians everywhere is very important and a very proven way to assure success. You also have to invest heavily into redundancies. You can't just turn on, your radiosynthesizer and hope, okay, here we go. You have to have plan A, plan B, plan C, plan D in case something happens. And that's in every regard. That's not just in production. You also have to think about the logistics. You have to think about the packages that we have. You have to think about even the staffing. It's worth having the extra logistics staff or trained individuals, cross-training them so that you have people that can, assure success in what we deliver. You also have to adapt to your customers. Customers like having their normal day-to-days, and you have to familiarize yourself with what they are, and then you have to optimize from there. So if a department wants to start at 6 a.m., be there for 6 a.m., change your production so that you can accommodate. Or if they want doses at, say, 10 p.m. or seeing patients at that time, make it for them, because sometimes we have to actually put aside efficiencies for production and think of the patient. There's a patient at the end of every dose. I know Valerie, who had a talk earlier, mentioned that every single dose we prepare is for a patient at the end. It's either that or we just throw it out. And we're not in the business of throwing out medication. We want to make sure people are being seen and treated. Another thing is exploring new technology. We've actually been in discussions with drone delivery companies to see how feasible that would be for more rural or remote locations. The thing is, it comes with its challenges, of course. Once there's a snowstorm or some sort of hiccup due to Mother Nature, it's kind of out the window, but it's another option that's feasible. Or like I mentioned earlier, the mobile PET labs or infusion labs that could be hitched on a trailer. That may be something we need to look at for the remote locations. And just be on top of your preventative maintenance. Everything, if you don't have a scheduled preventative maintenance on every single thing, including your vehicles, including your equipment for production, your retraining for employees, you're going to fail.
I just wanted to. Sorry, is this one working? Yeah, can you hear me? I'm Dr. Flemming from Newfoundland and Labrador. I'm a nuclear medicine physician and radiologist. I just wanted to hop on something that Carlos said there about the transportation, talk about the hinterland. That's us as well. We transported in FDG from you guys for quite some time. And that thing about the ducks, or perhaps a dead dog on the flight, your FDG is not getting on that flight. So, and now we're in a position where we can't even get Air Canada to transport something like FDG to us in a time frame where we'd actually be able to use it. So we've gone to chartering planes, which is now $25,000 per production to get them to a place like Newfoundland. So that transportation thing, that's a real thing. Yeah.
And Jeff, I'm glad you brought that up. I mean, we're talking St. John's, we're talking eastern side of Avalon, everything like that. But what about St. Anthony? What about Corner Brook? All these other things, which then get into what Carlos says. I mean, so Novartis, as you would have heard earlier, we were the first to move on a lot of these radiopharmaceutical products, and we learned all of these lessons right away to make sure. And now we're at, I think, at about 99% for delivery of our therapies. But it's figuring out the hard way, right? And it's figuring out, it's putting GPS trackers and doing all these extra steps that need to be done. But taking a step before the patient side of things, let's look to see what happened, not the commercial patient side of things, but frankly, clinical trials. And, Jeff, maybe I'll get you to go on there too, but, they're often built around major urban centers. And Chief, is happy to hear your thoughts as well. What do we need to change to actually make sure that they can get to patients and that this works in rural and Indigenous communities?
Thank you. Speaking as the chief of the Mississaugas of Scugog Island First Nation, we're located about an hour and a half northeast of Toronto. As the crow flies, we're the closest First Nation to the city. So we have the ability to come into Toronto. It's very difficult still. It's very cumbersome and expensive and time consuming. But we have that ability, unlike other First Nations who are more remote. But, clinical trials have traditionally faced challenges, including participants from rural and Indigenous communities, and really that stems from geographic isolation and limited access to healthcare services. And from an Indigenous standpoint, certainly historical mistrust related to unethical research practices of the past. So from our perspective, the issue is quite simple. Clinical trials are still designed for urban health systems, not for people and places like First Nations necessarily. So, what can we do to better the situation? Our suggestion would be to redesign around geography and people, not just institutions. So, for First Nations, being in clinical trial would mean long distance travel and time away from family and navigating what are really largely unfamiliar places and systems. And so that's a barrier really that's built right into the model. So of course it would be of great expense, but of great utility and benefit to bring the trials to the community themselves. Decentralizing approaches with regional hubs or mobile diagnostics and partnerships with local providers. So, radiopharmaceutical care is just in time, as they say, and so the trial access needs to be just in place. In our case, we have a pretty modern, professional staffed healthcare center and could bring in medical health to our First Nation to service the wider Durham region. So decentralized or hybrid trial models such as virtual visits and partnerships with local clinics are being adopted to reduce travel burdens and make participation more feasible. Another thing we could do is to really embed Indigenous governance in the design. So, so far our inclusion has been largely centered around recruitment targets, but communities really desire and need a role in design, in data governance models, and really defining what success looks like. So engaging communities both before and during the trial process to ensure that it aligns with local needs is critical to success, I would say. And of course, navigating cultural protocols and that kind of thing is required to engage the community themselves. So building trust through culturally safe systems, because trust will drive the participation. It's that simple. That means, providing patient navigation, family supports, and care pathways that reflect community interests. and leave the capacity in the community themselves. So trials shouldn't be really one-off engagements. They should build local capacity and training and infrastructure and long-term access for a partnership model into the future. Thank you.
Thanks, Chief. And Jeff, if you've got anything to add about that.
Yeah, I have more to say probably about the remote aspects of clinical trials, but I did want to echo some of the things that were just said. We have an excellent Indigenous patient navigator system in our hospital, which I think is really important to access whenever you have somebody coming from those communities, so you can understand better what their reservations might be with regards to embarking on a clinical trial. So I think that is really important to think about when you're putting together your clinical trial protocols. With regards to being from a remote part of the country, I think at times we get overlooked as potential sites to run clinical trials. I think we have a very vested community, lots of expertise. We have an excellent facility from a nuclear medicine point of view, because that's what we had to build to have a nuclear medicine program. We had to have a large facility because we needed not only to have the ability to produce FDG, but we needed to be able to produce everything that's going to have to be produced for the next 20 years. Plus, we needed to hire and maintain staff that would expect to have some sort of research capability to their careers to keep moving forward. So we have an excellent facility as they do in Halifax as well. But I think it's, and we've had a couple of instances over the past couple of months where we've actually started to embark on some of these clinical trials. So I do think it is improving, but I would say that, it's important to involve everybody, and certainly places like ours that are a bit more out of the way. We're still very interested in being part of these clinical trials.
And I mean, we look at clinical trials as some sort of innovative step forward, but realistically, it's also becoming a part of care, and it's where it either starts or where it stops. So, Chief, I'll come back to you on this, because you talked about working together and the before and the during process and the full process. Let's be honest. When we talk about partnership with Indigenous communities, what does it actually look like in practice? What does that mean to you?
Well, I think we've focused partnerships on things like recruitment and capacity building to some degree. But I also think we can look at things differently in terms of engaging the Indigenous community as sort of partners in the nuclear economy. So at our First Nation, MSIFN, which is my acronym for my very long community name, at MSIFN, our partnership starts with where we are and how we've chosen to engage. We are in the heart of nuclear territory and OPGs in our backyard. So we'd like to participate not just as stakeholders, but as rights holders, having treaty rights in the area, but most importantly as well as multi-generation partners in the nuclear economy. So again, I mentioned our strategic location. We're really a natural partner in the isotope economy, about 30 kilometers north of two of the largest nuclear generating stations in Canada where isotopes are harvested. So MSIFN is directly within Canada's nuclear and isotope ecosystem corridor, not on the edge of it, but really truly within it. But we have not yet joined the isotope ecosystem as a partner. So as members of CNIC through our Economic Development Corp, we are going to change that. And 2026, I hope, is a year to really watch MSIFN as we're positioned to be part of that isotope supply chain as strategic investors, as part of the workforce and the long-term infrastructure that supports the sector. So, I'm hoping there's going to be some groundbreaking announcements there in the next while. Secondly, we want to we want to build participation across the value chain. So our investment strategy is not project by project, it's really system-wide or system-based. And our focus areas are, again, supply chain participation with firms that can meaningfully benefit First Nations, direct investment in nuclear infrastructure along with industrial lands, logistics and services, workforce development and training, yes, and participation in isotope-related opportunities that improve access for our people and for people across Canada. And that means really aligning economic development directly with health system access. So really, to us, partnership really means equity, governance, and long-term value, but that governance piece cannot be forgotten. And again, it's what is the cornerstone of meaningful participation in shared decision-making and, yes, shared risk. So we've strategically structured our long-term economic agreements that create community benefit, such as a bilateral agreement we just entered into with the region of Durham. And we want to align our economic development, our economic participation with health outcomes. Partnership must improve access, not just expand industry. And we want to build place-based models. So really, when First Nations are positioned as partners, grounded in place, in equity, in long-term strategy, we don't just expand the isotope economy, we really strengthen that entire ecosystem.
I'm a big fan of you teasing out a potential announcement here on stage. Maybe next year or even sooner, I hope, where you can talk more about that. But I'll kind of leave that there. If anybody else has any comments on what partnership with Indigenous communities looks like from their own unique perspective, would love to hear it.
I mean, from our point of view, most or a large component of our Indigenous community lives in Labrador, and which is even more remote than Newfoundland. And so, when I think about that, it's mostly about access. And so the way that we're approaching that is decentralization. And so we're actually starting a West Coast PET program to give access to patients that are 10 hours away to so the beginnings of a theranostic kind of an approach to medicine. They'd still have to come to St. John's for the therapy part, but if we can start there and then hopefully get access, maybe we start to hire physicians. It's, our issue is always going to be about getting qualified individuals. Technologists and physicians are very hard to come by. And so the more that we can build up those more remote outposts, the better.
No, it's a good point, because I think when most people think of Newfoundland, they forget that second part there as well, Labrador City and onwards too. But if you're looking at kind of building out from there, obviously St. John's does have RLT capacity, as does a number of sites across. But when you're talking about building it into less urban areas, you just went into a bit there. But what would you say, like from your perspective, what's the first thing to invest in? What's the first step to take on that path?
So I talked about it a little bit earlier, but our first decision when we wanted to upgrade our nuclear medicine capacity was, how were we going to do it? Are we going to always be sending patients out of the province like we were for years? Are we going to be flying everything in from elsewhere, which ends up being fraught with issues, which I've just discussed a bit earlier? Or are we going to actually try to make a go of it and build our own facility? So that was the decision that we made. Now the investment up front is considerable, and more than just paying for a flight to St. John's with some FDG on it. However, in the long run, it's turned out to be really the financially most viable solution, just because of now all the difficulties that we have with transporting radiopharmaceuticals across the country. So we built a facility that was future-proofed, and we figured would be able to give us access and our patients access to what is going to be the forefront of nuclear medicine for 15, 20 years. That's the approach that we took. That's not going to work for everybody, but that certainly did work best for us.
And you mentioned the word access. That's the one that kind of, I think, should drive everybody's perspective on this, is to make sure that patients can actually access the treatments. That's from Novartis's perspective. We look for partnership where we can help make that a reality. And so it's not just in the core centers, but frankly, it's to all Canadians, because that's what we all want at the end of the day. Kind of going to the hub and spoke, the hub and local care perspective that we were just talking about, I'll throw this to whomever, but what is that right balance though? When you're talking about centralizing care in major hubs, bringing services closer, what is that balance that you can find, whether it's for Newfoundland and Labrador or anywhere else? And Ian, you had mentioned about going through a myriad of different communities when it comes to your wife's cancer care. What is that balance you need to find?
Well, I kind of hit on it at the start, I think. The trials have to go on, and all of us have talked about the trials going on in different places, and where the doctors leading the trials have team members in different places. 20 years ago, you probably couldn't do this because we didn't have fiber all over the place. We didn't have broadband. Now communications is really easy. There's way of communicating and having people there, and I think that's part of building up the network with different team members in different locations that can feed into the center and help A, do the tests or the trials, and B, do the treatment. The technology's there. We just got to figure out how to do it, or try and get our provincial government to build out the plan of the communications.
Carlos, Jeff, anybody else?
Yeah, I totally agree with that. I think it's really important to start getting access for patients in these smaller communities, because yes, you don't have technologists and you don't have physicians there now. They're never going to come unless you actually have a program for them to come to. So starting that process, I think, is the most important part of it. And we're an example of this. Eventually, you'll have the people come that you need to bring it where you want it to be 10, 15 years down the road. You don't have to have it all right off the bat, but having a satellite center with one or two people providing some sort of radio, RLT service is, you have to start somewhere.
Mayor?
You need people educated and trained. That's the other thing, that it's great having these placements, but we're going to need a workforce and specialized doctors, specialized technicians, all these people, educational programs built into it to fill these roles out in the different hospitals.
At the different hospitals where people want to get the care that they want to get as well. That's something I don't think we can lose, is patients can and will travel where they need to go, but people want to be home in times when you're dealing with a cancer treatment as well. Looking out past home and looking kind of around the world, Jeff, do you see anything where this is working, Canada or otherwise, that it can be improved, where you can take good learnings, where things have not worked out so well? Like, what do you look for as your North Star on what to build out for Eastern?
I mean, in traveling here and there to different countries to look at equipment and things like that, you get to talk to people from other places you wouldn't otherwise get a chance to chat with about stuff like this. And we were, recently in Europe chatting with some of the physicians in a relatively small practice, I guess, for Italy, about how to develop these smaller center types of practices, and they seem to have, come up with the same idea that I think we discussed this morning, the hubs around, like maybe a few hubs and then a few smaller ones that don't quite do everything, but do give patients the ability to get treatments, and then, maybe smaller hubs outside of that as well. That seems to be the best way. That's the path that we're following in decentralization in Newfoundland, trying to get people access. The intent in having a PET program across the province is eventually there will be therapies there too once we have the people there to do them. So I do think that's, this move towards decentralization, I think is the right way to go.
And just for a quick plug for Novartis, I will say when it comes to patients who need those supports in between getting to and from places, that's why pharmaceutical companies have patient support programs, is to make sure that it's travel, whether it's logistics, whether it's every step of the way. I say that on behalf of Novartis, but I think I say that on behalf of every part in the pharma industry, because frankly, you need to make sure that those steps aren't just afterthoughts. Thinking about where other communities are doing something, Chief, I want to kind of go from your perspective as well. Where do you see, when it looks to true partnership, who's done this right, or where we can kind of come back to what examples do you see that guide your work?
Well, to date, our First Nation has really own-sourced our funds to make sure that people get the treatment they need and get to the places they need to be to get it. So it's what I think when I look forward into the future, how we can do things better. I don't know that there's a beacon or a model that we can look at who's done it perfectly well or right. I think we're in a space and time in the reconciliation era, if you'll call it that, where we're finally taking note of Canada's history and the U.S. is actually behind us in terms of the progress we've made with Indigenous involvement. But I think what I'd like to see going forward is beyond recruitment, capacity building, again, a decentralization model allowing for greater access and not leaving it to the communities themselves to be so self-reliant and having to figure it all out on our own, and working with industry to help that happen. But I do think we can't discount First Nations partnerships. The reason I'm so focused on economic development is because for a number of reasons. Number one, we've been kept on the periphery of economy for the last 150 years, and I'm not saying that to make anyone feel bad. I'm just stating a fact that the Indian Act has kept our communities out of economy. And so right now we're in this race to build economy so that we can be more self-reliant. First Nations actually have access to federal and provincial program monies that otherwise wouldn't be accessible. And so what government is trying to do is position industry to partner with First Nations so that they have greater access to capital in terms of funding these programs and initiatives and infrastructure and all the things we need. And I think we're at a really good point in time where First Nations, unfortunately, we have been forced to ready ourselves to respond to such opportunities because of the elbows up economy that we find ourselves in. But it's a good time to quickly respond, and for the communities that aren't able to quickly respond, communities such as Scugog, as one example, will be the leaders in creating that model that you asked me about.
Appreciate that. Yeah, economic empowerment is, whether we like it or not, an integral part of all of this. We've had a lot of conversation. A lot of these things all kind of touch on what provincial governments do, what the federal government must do, and we've heard a lot of that this morning from NRCan and otherwise. Mayor, I come over to you, this mayor right here, and I'm curious, where do you see municipalities playing a role? I mean, you're up here playing a role, right? So
to start, a couple years ago, when CNIC did the Isotopes for Hope, there was a presentation. We looked at the book and at the plan and said, how can we help? And what can we do to be involved? And we looked very loosely at the research triangle in North Carolina and looked at that we've got industry that is producing isotopes with Bruce Power in our backyard just an hour away. We're looking at all the work that's going on at McMaster and down here in Toronto at hospitals and educational institutes. And municipalities, We go 3 times a year to different conferences with the ministers of the province and meet with them and try and get them to do stuff and talk them into things where we consider ourselves partners in a sense of the province. In fact, municipalities are just creatures of the province. We don't have any charter of rights of our own or anything else. We also are on top of economic development and what's going on at our hospital and what's going on with our industry in town. And we're constantly trying to sell our cities to attract new industry, which makes us salespeople, and it makes us perfect to be involved with the Isotope Coalition, building it out, lobbying provincial and federal governments, working with producers, manufacturers, the industry, working with medical facilities and kind of being the glue that pulls it all together. So municipalities, I think, are really important as we build out the Isotope Coalition and the whole industry going forward.
So it's whether it's elbows up or your voice up, but realistically, you've got to come to the table and 440 voices across Ontario at the very least to really kind of move things forward on behalf of your communities.
Elbows down. Elbows down. I want to work with other municipalities in my region. I want to work with Saugeen Ojibwe Nation in my region. I want to work with Bruce Power. I want to work with the companies as well as the government. Elbows down. How do we build relationships, work together, move the ball forward together? And everybody in this room has a corner of the piece of pie. How do you work with others that have the other piece of pie? How do you work with, how do you spread the word to those that aren't involved, that aren't in this room, that could be? We're all in this together in a sense. So I say elbows down and work together with others. Regionalization and collaboration.
I'll second that motion.
We'll see if it gets carried with unanimous consent. But before we go through the procedural stuff, we got a few minutes left, and I want to end it with a question, not the whole magic wand, what would you get rid of kind of idea, but I want the low-hanging fruit. I want the easy things. I want to hear from all of you what the next step should be that we can easily do together, independently, in whatever way, to get things moving so that care can make it into more rural, remote, Indigenous communities so people get the hope, the treatments, everything that they need. Carlos, I'll start at that end, please.
Well, I'm not going to talk about all the points that I had here, but I think working on the reimbursement model is a big thing. Awareness, so everyone knows the benefits. Road redundancies right away, some other paths to get to wherever they need to get to is very important. And I know it's been mentioned a lot, but the hub and spoke model, I think, is really primary here.
Jeff?
What is going to stop us from progressing? This might not be low-hanging fruit. It seems to me like it should be, but it's human resources and our technologists and physicians to maybe a lesser degree, but really the people who work in these departments. We are probably at 50% capacity right now with, we have half of our positions are unfilled in nuclear medicine. And I was talking to a friend of mine who's from a big place in Ontario thinking, I'm sure they have no problems whatsoever, and they're in exactly the same position. And so this is what's going to stop us from moving forward. We need more positions, we need more schools, we need more.
The easy things, okay. Chief?
I think, sort of final reflections, again, don't discount the ability to partner with Indigenous communities, and don't forget that we're a burgeoning partner. I wouldn't call us resources, we're assets. And so I think once the mainstream economy catches up and realizes that there's a lot of untapped potential there, not only to utilize our community's health infrastructure as regional, I guess, hubs, but I think there's a lot to be said for elbows down and working together with First Nations, because it'll be a little more win-win in getting the things done we need getting done. On medical trials, again, designed for people in place, not systems. On partnerships, partnership should equal equity, governance for rights-holding communities, and long-term value. And on, just speaking for MSIFN, on our role, we are not adjacent to the nuclear economy. We are part of its geography, we are part of its history, and we're definitely going to be part of its future. So, Chimigwech, thank you for listening.
Ian, anything to add?
I think it comes back to infrastructure and training of people and telling the world of what's going on. Like, just when you see the pictures on a PET scan of what's going on with cancer, with it shrinking, it's unbelievable. Like, I can't go back and tell the rest of my council what I saw on that screen. You know, we get to see it. You guys get to see it. You guys get to do it. It's phenomenal. So I think the potential is there. The future is amazing. How do we bring that future, the long-term growth, the long-term change in closer so we can get it out faster? And I think that's training of people and development of technology or of the infrastructure and equipment. And it's exciting times. I wish I was 40.
You're what, 42? 40, all right, 43.
Nine again.
Look, I thank you, everybody. I think if there's one thing to take, I mean, it is access isn't just one big fix. It is the basic things. It's pathways, it's people, it's coordination, it's partnership. So if we can get all those right, then yeah, this exciting future is here. And I think if we all continue to work together, it will be a reality soon enough. So without further ado, if you could join me all in thanking the panelists here.